real force behind the scene. She's handling the flyers, the spreading the word, and ensuring that the recordings were uploaded for everyone to revisit. I thank you, Reena Dua, for your extensive support always. I would also like to acknowledge the support and contribution of President of Delhi NCR, chapter of ECO, and the current Vice President of the National IAE, Dr. Manish Bansal, for always being generous to my requests and guide us with his expert comments. I would like to extend my thanks to all our presenters for coming forward, stepping out of their comfort zones, and presenting cases in this forum. Keep up your enthusiasm, and I'm sure this will definitely inspire others to come and join us to share your cases in the future. And thank you, Dr. Rakesh Gupta, for his unwavering support and encouragement always in conducting this program. His guidance has truly been invaluable in all these 7 sessions. He's actually the pushing force behind for me. Last but not the least, thanks to all the moderators, Dr. Vivek and Dr. Rohit, for being a great force, helping the presenters do their job and helping me handling the questions and the chat box. Thank you, both of you, for being there always. And thank you, lovely audience, for keeping us motivated, joining us here always, and keeping us on our toes to keep bringing you something exciting. I begin the program now by inviting Dr. Manish Bansal to start with this important topic of aortic dissection. Before he starts, I would just like to say that why I chose this topic was because acute aortic dissection carries high in hospital mortality rate. It is often misdiagnosed initially. It delays surgical intervention, and early diagnosis is critical for improving patient outcomes. So, if you all know, that's was one of the guys from our EcoMade Easy group. He has posted one video of a patient suffering with dissection and AR, acute AR, and he was wanting to confirm on that. So that clicked my mind that it is so much important that we focus on this entity, and I could not find anybody better than Dr. Manish Bansal to give us an overview of aortic dissection. Dr. Manish, over to you, please.
Good evening, everyone. And it is always a privilege to participate in this forum where I know that there are many young echocardiographers, clinicians, as well as sonographers who have so many questions, but a lot of enthusiasm to learn. And interacting with them is always very motivating and satisfying. So I'm going to talk about aortic dissection. I'll provide a brief overview. I'm not going to go into complex details, but just an overview of what aortic dissection is and how it appears on echo, and what all we need to keep in mind when we are doing echo in a patient in whom we are suspecting aortic dissection. So aortic dissection is one of the acute aortic syndromes. Overall, there are 3 main entities which are termed as acute aortic syndromes. One is aortic dissection, second is intramural hematoma, and third is penetrating atherosclerotic ulcer. Now, aortic dissection occurs when there is a tear in the intimal layer of the aortic wall, anywhere in the aorta. If there is a tear, then the blood from the lumen seeps into the space created between intima and rest of the aortic wall, and because of the force of the blood, it then extends either proximally or distally, can go into the branches also, and splits the aorta wall into 2. This is aortic dissection. Now this may end up with a rupture of the external layer also. In that case, it will be immediately fatal if it ruptures into the surrounding cavities. If it ruptures into pericardium, then it may cause tamponade and lead to death, but sometimes it may just get contained and may allow the patient to survive. On the other hand, intramural hematoma is a condition in which bleeding occurs within the wall of the aorta because of the rupture of one of the minor blood vessels present in the within the aortic wall, and that bleeding is contained within the aorta wall. So there is no rupture either towards the inside, towards the lumen, or outside. And the third entity is penetrating atherosclerotic ulcer, in which there is a tear in the intima, but this tear is not because of the force of the blood, rather, it is because of the ulceration of the atherosclerotic plaque. So, blood seeps into the aorta wall, but remains confined to a very small area because atherosclerosis usually causes fibrosis and scarring of the aortic wall, so it doesn't allow this collection to spread. So these are the three main entities: aortic dissection, intramural hematoma, and penetrating atherosclerotic ulcer. Now, of these three, aortic dissection is by far the commonest, and that is what we are going to talk about. Now, there's another term, aortic aneurysm, and sometimes people get confused when to call it aneurysm, when it is dissection. Now, in case of thoracoabdominal aorta, if there is any segment of aorta which has a diameter more than 1.5 times the adjacent segments, then it is called an aneurysm. So if the or the normal size. So if the normal aorta size is 3 centimeter and if it becomes 4.5 centimeter, then we will call it aneurysm. Now this definition cannot be applied to ascending aorta because in ascending aorta, 1.5 times enlargement may be too big, too much enlargement for the risk of rupture and dissection. So we cannot allow ascending aorta to dilate by 1.5 times before calling it aneurysm. So for this reason, in case of ascending aorta and aortic root, the definition of dilatation and aneurysm differs, and it depends on the risk of rupture or aortic dissection. So here, if we look at this chart is from MISA study. In this, on this axis, we have different sizes, and this is the relative risk of aortic dissection. So if we take the risk of dissection as 1 in someone whose ascending aorta size or aortic root size is less than 3.4, then it becomes 5 times. If the diameter is 3.5 to 3.9, it becomes almost 90 times. If aorta size is 4 to 4.5, and more than 6,000 times if the aorta size is 4.5 or more. That's why, based on this, any aorta, any any enlargement of aortic root or ascending aorta 4 centimeter or more is termed as dilated aortic root or ascending aorta, whichever segment is dilated. And if the diameter is more than 4.5, then we call it aneurysm. So the definition of aneurysm differs in case of ascending aorta and thoracoabdominal aorta. Now, whenever we come across aortic dissection, we also need to define it in terms of its location, the site of intimal tear, and based on this, there have been some classification proposed. The two most commonly used classification are DeBakey classification and Stanford classification. So, as per DeBakey classification, aortic dissection can be of three types: type 1, 2, 3. Type 1 is one in which there is tear in the ascending aorta and it extends to involve most of the thoracoabdominal aorta also. Type 2 is when the dissection occurs in the ascending aorta but remains confined to ascending aorta. Type 3 is when the tear originates in distal part of aorta, that is beyond the arch, and then extends distally. Okay. So this definition is basically based on where the tear happens. On the other hand, Stanford classification just looks at whether ascending aorta is involved or not. So if ascending aorta is involved, then this is type A. If ascending aorta is not involved, then this is type B. For practical purposes, Stanford classification is more relevant because the prognosis and management of dissections that involve ascending aorta differs from dissections that do not involve ascending aorta. So type A versus type B, and that's why most of the times we are using this classification only and referring dissection as either type A or type B. The dissections can also be classified on the basis of time since onset. So if it is less than 24 hours, then it is called hyperacute, 1 to 14 days acute, 15 to 90 days subacute, and more than 3 months chronic. This classification is also clinically very relevant because as the time elapses, the mortality rate in dissection decreases. So timing is also crucial. Now, why we fear aortic dissection so much is because it can lead to some lethal complications. So as I mentioned, dissection can end up with aortic rupture, and if it is a free rupture into the surrounding spaces, then the patient will die immediately. Sometimes it can lead to rupture into the pericardial cavity because most proximal part of aortic root and ascending aorta are covered by the pericardium. So if there is a rupture there, then it will lead it will uh, leak into the pericardial space and will cause tamponade. The ascending aortic dissection can cause acute aortic regurgitation, either because of interference due to intimal flap or because of sudden aortic root dilatation that leads to non-cooperation of aortic leaflets. Sometimes dissection involves the aortic valve apparatus and it can lead to aortic leaflets becoming flail. And lastly, AR can also be because of native aortic valve disease because as we know, aortic dissection is common in patients with bicuspid aortic valve. So a patient may be having AR just because of the bicuspid aortic valve disease. And then the third most common complication of dissection is vessel occlusion because as the dissection extends, the false lumen keeps on increasing in size and eventually becomes thrombosed. So, because of this enlargement of false lumen and thrombus formation, the blood supply gets compromised. And if a branch vessel is originating from false lumen, then there are high risk of vessel occlusion and malperfusion. So depending on what artery is involved, it can lead to either acute myocardial ischemia or infarction, stroke, or renal mesenteric or lower limb ischemia. That's also the reason why many patients with dissection present as acute infubol MI, and very often uh, they may I mean there may be situations where there is no true myocardial infarction. The patient is treated as myocardial infarction because of the presentation with chest pain. So dissection may be mistaken as uh, myocardial infarction because of chest pain, but it may cause true myocardial infarction also due to the occlusion of the branch vessel. So mortality rate is high, very high in acute type A dissection, with early mortality ranging in 1 to 2% per hour. That means almost 50%, 25 to 50% patients dead within 24 hours. And the mortality is even higher in those who present with complications. In case of type B dissection, the mortality rate is relatively lower, but it's still quite high, roughly 10% at 30 days, and much higher if there is complication like occlusion of a branch vessel or rupture, in which case the mortality rate may be as high as 20% by day 2 to 25% by day 30. So, so when a patient presents to us and we have to do echo, and patient has presented with chest pain where dissection could be one of the possibilities, then before doing echo, we need to look at the clinical presentation. We need to look at the patient's background, risk factors, and the type of chest pain. And all these will give us a lot of important information about the possibility of dissection being there. So we should not just jump to echo, but we need to look at clinical findings also. And based on clinical parameters, some risk scores have also been proposed, like this one, where we look at predisposing conditions, whether present or absent, like Marfan syndrome, family history of aortic disease, known aortic valve disease, recent aortic manipulation in the form of any surgery, non-thoracic aortic aneurysm. Then the type of chest pain. In case of aortic dissection, the typical patients typically present with sudden, sharp, severe chest pain, which is quite uh, intense to begin with, and the intensity decreases with time, and the pain usually occurs in the center part of the chest and radiates to back. That is in case of ascending aortic dissection. Then there are some clinical examination features that can also point towards the presence of aortic dissection, which we often tend to overlook. But if we just look at feel all the peripheral pulses, if we find any pulse deficit, that the pulse of one limb is missing, absent, if there is any focal neurological deficit, or if there is a new murmur of aortic regurgitation, or if the patient presents with shock. So all these conditions will also indicate the possibility of aortic dissection. Now, if there is any one factor present from any of these categories, then we assign score 1. So any condition present from here, 1. Any condition present from here, 1. Any condition present from here, 1. And based on this, we can assess risk of aortic dissection. If the total score is 0, low risk, 1 point, moderate risk, 2 to 3 points, high risk. Then there's another risk scoring, which looks at 6 parameters: hypotension, aneurysm, pulse deficit, neurological deficit, severe deficit, and sudden onset pain. Based on that, also, we can have an idea about the possibility of aortic dissection being there. So if we are suspecting aortic dissection, echo is the first modality that we use. Although we need to remember that in the evaluation of aortic dissection, CT is the most useful diagnostic modality because it gives us the most definitive information and information that is directly helpful for planning the surgery. But echo being the easily available diagnostic tool and having the ability to provide a lot of additional information like pericardial effusion, wall motion abnormalities, and so on. So echo also is an extremely important diagnostic modality in these patients. So there are some features on echo which should immediately raise our suspicion for the presence of aortic dissection. One, of course, is intimal flap. So if we find any flap in the ascending aorta, then even if the patient has not come with symptoms suggestive of dissection, we must suspect dissection being there. Then aortic root dilatation in a patient with chest pain, pericardial effusion and tamponade in a patient who is presented with sudden chest pain, new aortic regurgitation, or differential Doppler flow in a patient who is presented with chest pain. All these should lead to uh, uh, our attention going towards the possibility of dissection. Now, what we mean by differential Doppler flow is that if we are evaluating any part of the vessel, whether it is ascending aorta or any distal vessel, and if we apply color and we find that we are seeing two different color patterns, then that is known as differential Doppler flow. I'll show you some images of that. So these were the red flags that should immediately alert us towards the possibility of dissection. But as a whole, what all we need to look at when we are doing echo in a patient in whom dissection is a possibility. So first, of course, is to confirm the presence or absence of dissection. For that, we'll look at intimal flap. If we find intimal flap, then we need to see where it is originating from and to what extent it is going to. So it is extending. Is it extending to arch or distal part of abdominal aorta or limbs or branches? All that we need to look at. We need to look at aortic root size, ascending aorta size. We need to see whether the aortic valve is bicuspid or tricuspid, whether there is any stenosis or regurgitation, and if there is regurgitation, what is the mechanism of that? Any wall motion abnormalities, what is the EF? Because as I mentioned, aortic dissection can involve coronary arteries and can lead to acute myocardial ischemia and wall motion abnormalities. Then pericardial collection and tamponade, and lastly, involvement of the branches. So here we have one example. So this is Plaque's view. As we can see, there appears to be LV systolic dysfunction. Mitral leaflets appear to be tented, mildly thickened. But the most striking finding is that aorta is dilated. there is effacement of sinotubular junction here because we cannot see any demarcation between aortic root and ascending aorta. Aortic leaflets appear mildly thickened, and we see this flap just distal to the ascending aorta. So this flap is away from the aortic valve, unrelated to the aortic valve, and freely oscillating within the ascending aortic lumen. On this side, we see there is significant AR, but here I don't see any part of the flap coming in contact with the aortic leaflet. So most likely this AR is unrelated to this flap. This could either be because of the thickened aortic leaflets or just the dilatation of the aortic root. Because as I mentioned, if there is a dilatation of the aortic root, it will lead to non-cooperation of the leaflets. So here we have three short axis views at different levels. This is at the level of the aortic valve body. We don't see any dissection flap here. We go up, we start seeing this dissection flap here, and we go further up. We don't see any aortic valve leaflets here now because we have gone beyond that level, and we are seeing this uh, the lumen of the ascending aorta with this flap, and basically there are two different lumen. So one this one and the other is this lumen. So once we see this, we also need uh, to identify which one is true lumen, which one is false lumen. I'll come to that also in a few minutes. So now, when we see this kind of image where there is a flap, or so here in this case, the flap is very clear, but sometimes it may not be that apparent. So then we, in those cases, we can go to short axis images and see whether the flap is there or not. And sometimes there may be artifacts also which can create confusion. So in those cases also, if we go to short axis, it makes it a lot easier for us to identify the presence of dissection. This is same patient. Here, this is abdominal aorta. We can clearly see dissection flap here and flow between the two lumen which are created. This shows forward flow in this lumen. So as we can make out that this thinner lumen should be the true lumen because we can see forward flow. This the other lumen, which is much bigger, doesn't show any flow. So most likely this is the false lumen. And this is the short axis image that we are seeing here. If you look at this, if you in color, we can see differential color flow. We are seeing flow only in this part. If we use PW also, then also we'll see that flow pattern is totally different between this part and this part. So that is what is differential flow, which I had mentioned in the previous slide. Okay. So once we see this kind of image, it becomes very clear that this section is extending to the abdominal aorta. In fact, for any vessel, if you want to know whether dissection is extending to it or not, just uh, do the short axis imaging of that vessel. So for carotid, put your transducer on both sides of carotid in short axis. Similarly, go to the groin and put your transducer at the femoral artery in cross section so that you get the short axis of the femoral artery. If you see any flap, then that means that the dissection is extending to that vessel at least. So that way, it is very easy to identify whether dissection is extending there or not. Another patient. So here we can see again dissection flap, and this flap is prolapsing through the aortic leaflets during the cardiac cycle, and because of this, there is significant regurgitation. And here in this patient, this is the subclavian artery, left subclavian artery. We can see dissection flap in long axis also. Because subclavian artery origin we cannot see in short axis. So here we have to look at the long axis view. We can see dissection flap. This is the arch ascending aorta in this patient. So the image taken up from a higher up intercostal space where we can see more of ascending aorta, and we can clearly see this flap. So what is happening here is this is the aortic valve. So this is the true lumen, and then that the blood flow has resulted into a tear in the intima, and this false lumen has been created. So in this view, it is easy to identify that this is the false lumen. If we just follow this, we can identify where all this false lumen extending to. Another patient, again we can see a flap in the ascending aorta, very close to the aortic valve leaflets. Ascending aorta is dilated, and here this aortic leaflet has become flailed because of dissection, and there is significant AR. So same thing in short axis, we can see this flap interfering with the aortic leaflets and dissection. Now in this patient, the dissection was confined only to ascending aorta, and that's why we don't see any evidence of dissection in the abdominal aorta. So this is the thoracoabdominal part. There is uniform flow in the lumen, and there is no dissection flap here. Now here, if you look at this patient has dilated aortic root. There is no doubt about that. The aortic leaflets are thickened. Now, when the aortic leaflets close, we see this white line. So sometimes it can create the confusion that there could be some dissection. But this is actually not a dissection. This is just a side lobe artifact which is intermittently appearing. So how we differentiate this from true dissection is that this is actually a linear structure, just a line, thick line, which becomes intermittently visible. It is not really mobile, and in short axis, we will not be able to see this. And if we use color also, we will not be able to see any differential flow. Another example, this is a patient who had come to me with history of back pain after heavy weight lifting. So, and he was hypertensive, obese. So in this patient, aortic dissection was definitely a clinical possibility because he had sudden pain after lifting heavy weight. So I was worried. When I did echo, I found this kind of appearance. His acoustic window was not that great because he was obese. So as you can see here, there is this white linear structure, and it definitely suggested a possibility of dissection. But because acoustic window was not good, I was not able to evaluate ascending aorta better. So I looked at abdominal aorta. And then in abdominal aorta also I found a linear white line, white structure, which raised a suspicion of dissection flap being present there also. So this was really very, very confusing. But then after some more imaging, I realized that that was not dissection. And why it was not dissection, that is depicted here in this long loop. So here I am sweeping the transducer from ascending aorta to IVC and see what happens. So this is IVC. This is the posterior wall of the IVC. When we sweep the transducer towards this abdominal aorta, we see same white line in the same place where the IVC posterior wall is. So actually, the line that I was seeing in this image was a beam elevation artifact, because what happens is that ultrasound beam is, although I'm seeing one thin slice, but ultrasound beam is not thin slice, it has certain width. So anything which falls within the ultrasound beam will be missed. So if you look at this short axis of the same thing, this is the this is the abdominal aorta, this is IVC, this is the posterior wall of the IVC, which for some reason is echo bright. So when we do long axis imaging, our ultrasound beam is going like this, but because it is lying close to it, reflection of this also gets seen in the same image. So we see a white line corresponding to this in aorta here, creating confusion of aortic dissection. But if you look at this color image, there is no differential flow. We don't see any flap in short axis. So that is how we can differentiate this flap, this kind of appearance from true aortic dissection. So same applies to ascending aorta also. If we find any difficulty, we should go to short axis imaging and use color to see whether there is a flap seen in ascending aorta, whether there is any differential flow. And lastly, as I mentioned, we need to identify false lumen, because if a branch is originating from false lumen, then it will get occluded. So there is going to be high risk of branch occlusion. And when we manage this patient, we will have to take care of that branch vessel occlusion also. So how we identify false lumen and differentiate it from true lumen? There are some clues that help in that distinction, but it may be very, very difficult many a times. But generally, false lumen is much bigger compared to true lumen, because as the blood uh, goes into the false lumen, it keeps expanding. Then, because here the blood flow is sluggish, it tends to thrombose. So false lumen gets thrombosed very soon. So this is beginning after some time and then later. So because of this thrombosis, also this lumen becomes bigger. So first is false lumen is bigger than the true lumen. It is often thrombosed. The blood flow is sluggish here. In case of true lumen, the blood flow will be more brisk. So these are the pointers that help us in distinguishing false lumen from true lumen. And another pointer is that false lumen generally lies towards the outer curvature of the aorta, whereas true lumen is towards the inner curvature. So I think this is all that I wanted to discuss here. Any questions, I'll be happy to answer. Thank you so much.
Yeah, thank you, Dr. Manish. It was quite lucid, very informative. I'm just asking one question to begin with. Will the curvilinear probe be more helpful while you are trying to interrogate the descending aorta rather than our regular phased array probe? Because that gives a bit better you know visualization of the vessel long axis.
Yeah, so the no, actually, we've all been using phased array transducer. We
Yeah,
have no
yeah.
experience of using curvilinear transducer.
Yeah, because whenever I
Uh,
have been talking to the radiologist and I
uh,
call them, so they generally use this and they say that you please try this one and it will give you a better outlook. And particularly also in portal vein
yes,
interrogation.
ideally it should,
Yeah,
but in our echo machines, we don't have that
yeah,
transducer. So
yeah,
only two transducers that we have is a linear array or phased array. So we have
yeah.
actually we don't have that option.
Yeah, so those who have, we can always do that because
Yes.
our machines
Yeah.
are generally mixed machines, so we have the curvilinear probe as well, and I think that gives a very good outline of the vessel.
Yeah, that is good for abdominal imaging.
Yeah, correct, correct. So any question from the audience, or you have understood it all very well? Come up if there are any questions. So I think RCA is more commonly involved than
Yes.
other arteries. That's a more commonly involved artery
Yes, yes,
in type
yes,
A dissection, Stanford,
yes,
right?
yes,
And
yes,
also that the beginning 2 to 3 centimeter of the aorta is the most commonly involved in the even in the ascending aorta. It is the
yes,
proximal 2 to 3 centimeter
yes,
which is
yes,
more commonly involved. So I
yes.
think
Most of it,
eco can do a lot of information, give us a lot of information if looked properly.
the type A dissection is the most dreaded uh,
Yeah,
variety, and type A dissection can be diagnosed with echo very easily.
yeah.
For type B, there will be a challenge, but type B is less dreadful also.
hmm And also,
And
we should be interpreting the history, the symptoms of the patient, the
yes,
teetering kind of, presentation.
yes, most often the patients present with history of severe chest pain, and that is almost invariable. Only sometimes it happens that the patient comes to echo room for routine echo, and we find that he is carrying a dissection also. It has also
Mm-hmm.
happened,
Mm-hmm.
but most often it is acute presentation. And one thing that we need to remember is that type A dissection, regardless of the time duration, whether it is 1 day old or 1 month old or 2 months old, has to be treated surgically.
Mm-hmm. Okay.
So
Okay.
we cannot miss type A dissection at all.
Mm-hmm. Another question, Dr. Manish. The aortic root dilatation. I think the mark is the 4 centimeter mark. More than 4 centimeter of aortic root is dilated is like pointing more towards.
4 centimeter is definitely dilated, but for people who have got smaller body size, in them we need to use index parameter. So
Mm-hmm.
there are different conventions for that. We can index to body surface area, but height is more commonly used. So aortic diameter by height. and there are
Yeah.
nomograms available for
Mm,
diagnosing dilated aorta based on that. But
mm,
above 4 centimeters is definitely dilated, and
mm.
more than 4.5, we can call it aneurysm also.
Okay. And is leading edge to leading edge is the right way, or the outer edge and leading edge, meaning the anterior wall and the posterior wall? What is
So
the
for
best recommendation? Because as far as the CT comparison is concerned, there is a 2 millimeter difference in these two ways. So, what do you recommend that what should be the
so
best way to measure?
if we measure diameter of aorta, then and if you are using leading edge to leading edge technique, then that means that we have measured lumen size
Yeah,
and we have measured thickness of wall on one side.
yeah, correct.
Okay, so our diameter is going to be bigger than the CT diameter because CT
Hmm,
will measure actual lumen,
hmm, 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 hmm.
and in aorta, in echo, we are measuring lumen plus one side of the wall.
Wall.
But why we use leading edge to leading edge is that most of the data that has been generated in studies that had used leading edge to leading edge technique.
Hmm, hmm,
So our reference values are derived from those studies. However,
hmm,
in current time, it is preferable to use lumen to lumen size, and because that correlates better with CT.
hmm, hmm.
So we should just mention that this is how we've measured.
Correct, correct. Thank you so much. Madhav Bansal is wanting to ask any question. Madhav, unmute yourself and ask your question.
Yes, sir. I wanted to know more about aortic dissection presenting as MI.
So
Uh,
actually, as I mentioned, two different scenarios happen. There are so many patients who have been thrombolized also because of their presentation with chest pain, and they actually had aortic dissection. So obviously, most of such patients will end up with only one outcome. Even heparin, any antiplatelets, all can be detrimental in these patients. But aortic dissection can result in true MI also because of occlusion of the coronary artery due to the dissection process. So in that case, it will be very, very difficult to differentiate that based on ECG and even chest pain presentation. Unless we do echo and we find dissection flap, it will be really difficult to diagnose that kind of myocardial infarction.
okay,
Yeah, but
ECG,
huh. Go ahead, go ahead.
ECG will show ST elevations.
Yeah, ECG will show typical MI changes, STEMI changes. The only thing is that if we take the history properly, and if the patient says that the pain was very intense to begin with, and then the intensity decreased, and it was radiating to back, so then that should alert us to the possibility of dissection. The other thing, which is in all our patients who present with chest pain, we should feel all the pulses, upper limb, lower limb
Yeah,
pulses.
correct.
Very often there will be pulse difference or pulse deficit, which will tell us that the patient is having dissection.
Dr.
Okay.
Manish, there's a question from Sonali Bhaumek. She's asking that if we are not able to see a dissection in one view, what all views we can be using to find it out.
Okay, so when we do echo, we first start with plaques. So most often we will see a dissection flap in plaques view. If you are not able to see a dissection flap there, then we can use high ascending aorta view. For that, we don't have to do much apart from just sliding the transducer one or two spaces higher up. So rather than the usual third intercostal space, we go to second or first intercostal space. That shows ascending aorta better. If you are not able to see the flap even there, we should go to short axis of the aorta, aortic valve, and then you tilt your transducer gradually upwards. You should be able to see a flap there. If you're not able to see flap even there, then look at abdominal aorta and or put your transducer on the carotid vessels. So those are the ways in which you can look at a dissection flap.
Yeah, so all possible ways should be actually explored right from and bringing the aorta, ascending aorta right in the center of the view makes it more actually accessible and more visible we can see that the intimal flap may be seen in such a situation. So I think we should conclude here, because there are two more presentations. And thank you, Dr. Manish. The images were very good and very nicely explained the stuff we actually wanted to communicate. So thank you once again for giving your valuable time and energy. You are not looking well. Thank you so much still.
Mhm.
Yeah,
I
because your
think
throat
some
was,
residual respiratory infection, intermittent cough, and
yeah,
some
correct, correct.
hoarseness.
Yes, yes. But thank you so much for doing this for all of us and enlightening us with the aortic dissection. I hope people working in the emergencies and routine echo labs, they'll be keeping this all in their minds. Now, what are the echo flags for the aortic dissection? So thank you so much, Dr. Manish. And we now move on to next presentation on RAC sign. I'm inviting Dr. Ranjan Kumar, who is from Patna, a very good colleague of mine and intensively involved with echocardiography. He has done a lot of cases, wherein he could find this sign, and he was once discussing upon this sign with me. So I was also not very well aware of till that time that what is this RSC sign and how does it look like, because it used to get very confused with the coronary sinus. So I requested him that someday, we should present it to the people, to people of my group. And I would also want that all of you should be aware about this sign, that what is it, because this may just come like this in your routine echo. And if your mind knows about it, your eyes will catch it. So over to Dr. Ranjan. Please enlighten the audience with your RAC sign.
A very good evening to all. Today I will be discussing a sign which is seen on a transthoracic echo. It is known as a RSC sign, and the tagline is "You won't see if you don't know," because it is very easily overlooked by any other people if you don't know. Uh, this sign is defined as a specific transthoracic echocardiography finding. It appears as a bright tubular hyperechoic vascular structure with a central lumen, which is located in the AV groove slightly on the arterial side above the mitral valve plane. And it's usually typically it represents anomalous left circumflex coronary artery, but sometimes there may be an anomalous left main coronary artery also, but very rarely. And to understand this sign, we must understand and know the difference between the normal and anomalous coronary course. So in the normal anatomy, the right coronary artery arises from the right sinus of valsalva. Then it runs anteriorly in the right epigroove. Where on the left side, from the left sinus, left main coronary artery normally arises, and then it divides into two, into the LAD, which runs anteriorly in the interventricular groove, and the LCX, which runs posteriorly in the left AV groove. This is the normal course of the coronary artery. Whereas in the context of this RSC sign, the anomalous LCX origin, which we see on the echo as a RSC sign, it's either arises directly from the right sinus of the valsalva or from the proximal part of the RCA. And then it takes the retroaortic path that is behind the aorta, and then it passes between the aorta and the atria, and then it reaches to the left AV groove. And this is known as the anomalous LCX. That is the anomalous origin LCX. Now, first, before we go to the RSC sign on the echo, we must understand and correlate it with the CT coronary angiography. Because the echo, we see some part of this sign, but the CT is the gold standard for diagnosing of this sign. And here you will see the origin and the course also. So the upper part of this slide is showing the normal and normal coronary artery, and the lower part is the anomalous origin of the LCX. So here, this is the real picture of the CT coronary angiography, and this is the right sinus of valsalva, and here RCA is arising. On the left side, left main arises from the left sinus, and then it divided into the LAD and the LCX. And here, this is the schematic diagram of this same. And you can see that after originating from the left main, LCX is running posteriorly into the left AV groove. But in case of this anomalous origin, there the LCX is not arising from the left side, either it is arising from the proximal part of the RCA or directly from the right sinus of valsalva. And here it is curving back behind the aorta. It passes between the aorta and atrium, and then it reaches to the left and AV groove. So it is this part of the course of the RT we are seeing as a RSC sign of the echocardiography. So this is another view of the CT angiography. In here, another beautifully depicted. This is the anomalous LCX. It arising from the right sinus of the valsalva and passing between the aorta and the left atrium, and then reaching to the left AV groove. So, as per the concern of the prevalence, one study has reported from 0.3 to 0.8%. That means out of 1,000, 3 to 8% person will be having this anomaly. And regarding the sensitivity and specificity, it has got a moderate sensitivity and it very high in specificity, almost up to the 94%. So if you are seeing the RSC sign in the echo, it is very likely anomalous retroaortic LCX. But if you are not seeing, you are not totally out that it is not present. It may be still present there. And though it is a transthoracic echo is a screening tool with high specificity, but the CT coronary angiography is the gold standard for the confirmation of this, as we have seen in the previous slides. And when you are suspecting ischemia, then we must go confirm it by the coronary angiography. And when the more detailed anatomy is needed, then MRI is the choice of investigation. So how to see in the echocardiography? So it is seen in the modified apical four-chamber view. This is the most consistent view for detecting the RSC sign. And here you have to slightly tilt. Hello?
Please mute yourself.
Here you have to tilt the probe slight anteriorly, and you will see it if it is present. If you will see it is as a tubular hyperepic structure running perpendicular to the aortic root, just above the mitral valve plane. It can be seen in the other two views, like two-chamber or three-chamber, but less commonly. Here now in next few slides, I will show you some examples of the RCA sign I found in my patients. This is what I found from the literature. This is the tubular structure just in the AV group above the mitral valve plane, and this is one of the patients. Here you can appreciate that this is a bright tubular structure just in the AV group above the mitral valve plane. Here is another patient in this. This is the image, and this is the running image, and just try to concentrate. Or this is there is a thin tubular structure like showing in this, and crossing from left to right, just in the AV group above the mitral valve plane. And the same has been confirmed by the CT coronary angiography. This is the 3D construction of the same patient. And here, this is RCA, and this small thin is the LCX, which is arising directly from the right sinus of valsalva and then running behind the aorta and reaching to the left AV groove. This is another rotated view of the same patient. And here again, you should appreciate that this is the LCX running behind the aorta and then appearing into the left AV groove.
Dr. Ranjan, I'm just interrupting for a second.
Yeah.
Just for the audience sake. So normally the place where you see the aortic root. Okay,
Yeah.
so this is a modified view wherein you generally get, like, while you are switching over to make a 4C, 5C, it is then when you come across this sign, right?
Yeah.
It is generally found in the area where the aortic root is visible. And also that in the CT you are seeing that it is going behind the aorta posteriorly. Yes.
Yeah. So, between aorta and the left atrium.
Yeah, correct. So that is why it is seen like this.
And that is that portion is seen by seen in echo.
Correct, correct. The one which is going behind the aorta.
Aorta, yes.
Yeah. All right. Please
Okay.
go ahead.
So I will show you a few more images and running images so that you can appreciate and just to confirm that okay, this is the RSA sign and not to be dismissed as artifacts. So here is another patient. You can see this is the two-chamber view, and this is the same tubular structure is same. And this is slightly modified. Again, you are seeing that same tubular structure. And this is again, this has been confirmed by the CT coronary angiography. However, this picture is slightly rotated, and in this side, this is the right sinus of Valsalva, and this is the LCX. It is rising directly from the right sinus of Valsalva, and then coursing behind retroaortically behind the aorta, and then reaching to the left AV groove. Okay. Now, this is another patients, and here in the different view, in the almost all view, this sign was seen. This is the fourth chamber, and this is the short axis view in the aorta. Here you are seeing the two tubular structure. This one is the LED, which is directly arising from the left sinus of Valsalva, and this tubular structure is the anomalous LCX. And even you can see in the plaques, modified plaques view, this is the tubular structure. So it is very prominently seen. If you know the sign, you will see it. Okay, when it is present. Okay, and this again, this same patient was confirmed. Here, this LCX is arising almost from the proximal part of the RCA, running behind the aorta, and then it is appearing in the left AV groove. Now another patient, the same. The purpose of showing the multiple you can appreciate and know that this is the structure which is known as RSC sign, and it will be it will represent the this anomalous course of LCX.
Yeah, they should imprint this in their mind that a structure seen something like this is an RAC sign.
In this patient, it is again this is present in the fourth chamber view, and this it is the two chamber view, and this is the third chamber, three chamber view. So this sign is seen in all, but not in all patients. Sometimes it's seen only in the fourth. Most commonly, it almost always seen in the modified fourth chamber view. So this patient again confirmed by the CT coronary angiography. There are two more echocardiographic signs known as a complementary sign. And when they are present, they increase the diagnostic accuracy of this sign. They are known as the Blebe sign and the tunnel sign. And this is the Blebe sign. This picture is from the literature, and this Blebe sign is appear as a equilucent dot type Blebe-like structure in the behind the non-coronary cusp. And the tunnel sign is it is a sign just parasternal short axis view appear as a tunnel structure behind the aorta. Now I have able to appreciate in few of patients because it is not present in all of the patients. This is how normally you see the coronary artery in the short axis view. That is the right coronary artery and the left main coronary artery. And this is the tunnel sign, short axis view, and there is a thin. This is a tube-like structure, just behind the aorta, then known as the tunnel sign. Sometime you may get, and this is the Blebe sign, and this is the Blebe sign. It is in the just below or behind the this non-coronary curves. It is present. So when they are present, they add the accuracy in diagnosing of the RSC sign. Now, what is the clinical significance? So generally, most of the generally they are benign. Most of the patient remain asymptomatic. However, there are certain situations where this type of patient, this patient may be associated with myocardial ischemia, angina, myocardial infarction, or sudden cardiac death. And there are few feature like slit-like ostium if there is a narrow elongated coronary origin, or if the course is intramural course, then these type of symptoms appears in that patient. And there are few area where it is very much important to know beforehand. If you are going for the surgery like aortic surgery, aortic root surgery, or mitral valve surgery, then the surgeon must know beforehand. Otherwise, unrecognized retroaortic LCX, it can be accidentally compressed or cut during the aortic valve operation. And when you are performing an angiography or angioplasty, then anomalous LCX may need selective cannulation and a different catheter. So if there is a prior documentation, the operator know where to look and which catheter is to use. So the artery is found faster and there is a less chances of less radiation and the radiation and contrast exposure. So these are two areas where it has got a clinical significance. Now, there are few structures which can be confused with this RSA sign, or otherwise leading to the underdiagnosis of this sign. The artifacts, it's in contrast to the RSA sign, it looks irregular, spotty echo, and it does not follow a normal anatomy. It may be seen in only one view, move or disappear with a small probe angulation, and disappear or become exaggerated with minor gain changes. And if you put a color, you won't get any luminal color flow, or maybe there is a color noise or no signal. Another possibility is aortic valve calcification, but it can easily be ascertained that this move with the valves, and it's like the lumen, dark lumen. One of the rare complications of infective endocarditis, mitral aortic fibrosis abscess, it may be confused with, sometimes may be confused, but it appears irregular, equilucent or equidense mass, and it lacks the smooth tubular appearance of the anomalous LCX.
Yeah, and the clinical history will also be relevant in such a case. So this is a differential of the bleb sign basically, seen in the plaques view.
Plaques view. Okay, it is seen between the mitral leaflet and non-coronary cusp of the aortic valve, mostly.
Correct.
And one of the most important this differential diagnosis is the coronary sinus. Everybody see this coronary sinus. But here the angulation of probe is not anterior, but when you angulate probe more posteriorly, you may get a tubular structure. But it is in contrast to the anomalous, it is a larger and it has got more dark lumen, thin walled venous channel. And again, if you put color, then it will be a low velocity, a continuous venous flow. And I am showing few picture of this coronary sinus. This is the still image, and this is the running image. Okay, so you may get confused that it is a tubular structure, but one of the important point is that its size is changing with the angulation and movement. Another differentiating point is it is more in atrium, more towards the atrium, not just above the mitral valve plane. This is another. This is again. This is the coronary sinus. It is more in the atrium, away from the mitral valve plane. And another one, which can easily be confused with this tubular-like structure. But important point, it is shape is changing with the movement of the heart, whereas in case of anomalous corrosion, the shape will remain the same.
Dr. Ranjan, again, I need to just add on one more thing for the audience, that the coronary sinus is actually the largest vein of the heart, which lies again in the interventricular, this AV groove posteriorly.
Posteriorly, but more towards the atrium.
More towards the atrium, and that is why it is looking like, the RAC sign. Both are tubular signs. Today only I came across one of this, and I was about to send you the image, Ranjan. And because it looks so much similar, and Dr. Ranjan has taken these. The coronary sinus is usually seen as a little larger structure draining, and but he has chosen these images because here the tube is quite narrow, But
Yeah,
he's right that with the imaging, the expansion is quite to an extent. It is more in the atrium, and you would see that the RAC sign was more towards the root and above this plane.
yeah.
Right. So it is important that we differentially diagnose it because I think that is the most common DD of
It is
this
an
sign.
NDD of this time. Yeah.
So that's where we land into confusion. That
Mm-hmm.
is this coronary sinus or is this RAC sign? Yeah.
Okay. So, okay, what is the clinical algorithm? That means you got the RSC sign, you confirm that it is RSC, then how to approach it. So it is mostly an incidental sign, and if patient is asymptomatic, there is no ischemia, no planned cardiac surgery. So you should report in the echo report that this is a RSC sign, highly suggestive of anomalous LCX with a retroaortic course, and then no further action needed for that patient if the patient is remain asymptomatic. But if RSC sign is seen with the patient with angina, positive stress test, arrhythmia, or LV dysfunction, then we have to do the CT coronary angiography to define the origin course. And if there is a definite ischemia, then we should go for the invasive coronary angiography if the PCI is being planned, consider. And if RSC sign detected before surgery, aortic surgery, mitral aortic root surgery, then we must treat it as a surgical red flag, and surgeon must be informed so that the prosthesis size, position, or suture line are modified to avoid LCX compression or cutting during the operations. So this is how you approach if you get the RSC sign on this. In March 2024, first I came to know this sign. And since then, I have been able to pick up this sign in 23 of my patients. And the last one is just 12th December. And out of these 23, 10 underwent the CT coronary angiography, and all 10 were confirmed with further anomalous LCX. So this not only show the very high specificity of this sign, but it also tell that once you know it, and if it is there, you will see it. And when you see it, you can trust this sign. Okay. So in conclusion, always consider RSC sign when a bright tubular structure is seen above mitral valve plane, typically seen in a modified apical port chamber view. It's mostly benign, often incidental, detected during routine echocardiographic assessment, and the transthoracic echocardiography is often the first modality to detect coronary anomalies. So, thank you for the questions sharing.
Fantastic, Dr. Ranjan. Fantastic. I think we have a mixed audience here. Many of you must be knowing about this topic, but those who do not know about it, because whenever we know something, then we look for it. And honestly, when Dr. Ranjan was discussing with me, since then I have also caught so many RSC signs. So that was the idea actually to make all those who did not know about this sign to be aware and catch it, though it is benign, but at least the course can be told to the surgeons or to the interventionalist, because nowadays tower and all, they are quite popular. So the if it is there, it will help the interventionalist. Thank you so much, Dr. Ranjan, for taking out time, and it was a very lucid presentation, very eloquent, and I think everybody must have understood. Any questions, do ask us. We will keep responding in the chat box. Dr. Vivek, please keep doing that, once you get any chat question in the chat box. And we move on to our next presentation because we are already getting late. Dr. Soni Rungta, I invite you to present your case. This is also a very, very interesting case. Stay with us and you will really be enjoying this case. Over to you, Dr. Soni. Soni was there last time also, and she did a great job. Soni, just go a little slow for the sake of the audience. Unmute yourself.
Yes, ma'am. Thank you, ma'am.
Yeah.
So good evening, everyone. Thank you for giving me this opportunity. Special thanks to Hansa Madam and Dr. Vivek Solere sir for giving me this opportunity. Today the topic will be think outside the window. Unconventional eco views changes the diagnosis. We'll see how it does. Just
Any glitches, Sony?
yes, ma'am. Just the window was not.
Yeah.
There was a 70 years old man admitted in ICU with a history of progressive dyspnea, orthopnea, PND grade 4 since last 3 to 4 months. He was a known case of hypertension, diabetes under treatment elsewhere with infrequent consults. On examination, his saturation was 82% on room air. Pulse was 108, which was irregular with frequent ectopics. BP was 86 by 56. On examination, he was having pedal edema, neck veins were engorged, and there were bilateral extensive crepes were there. His ECG was showing low voltage QR pattern in anterior chest leads with frequent VPCs. Treatment was started for the pulmonary edema and echo was ordered. Slide is not moving.
Click again and see. I think you remove your laser pointer. That causes some problem.
Okay. There is some glitch with the. It is not working.
Okay, guys, just bear with her. I think
Yes,
we'll
ma'am.
be.
Yes, ma'am. And on echo, when we went for an echo, his plex view showed dilated LALV with poor LV function. The window was not good as because of his old age and as he was very dyspneic. This is the short axis view of the patient. From here, he was having a very global, there was a global LV systolic dysfunction as we can see from the short axis view. His pike 4-chamber, we could not get a very good 4-chamber view. As you can see in the windows, the 4-chamber view was not good. So we attempted a subcostal view, but still not much information could be gathered from here. As you can see in the slide, as we have to provide the reports, so we reported it as the patient is having global LV systolic dysfunction with an EF of 30%. We ordered an X-ray chest, which showed a boot-shaped heart, as we can see over here. So we tried to we went for the echo to get so that we can get a more information if we could. But the window was still very poor, so we ordered for a CT scan. As you can see see over here, his CT chest showed cardiac calcification, which was one of the reason for a poor window. We again went for to redo
Only
his
you go
echo
back
and
to the CT and highlight the
Yeah.
calcium.
Okay.
Explain the CT more.
Okay, ma'am. As we can see in this, yeah, here is the calcification of the left ventricle wall, which is obliterating the window. And over here, this long. Here we can see the
See also in this
calcification.
window, Dr. Soni, in this window, this CT longitudinal, you can also see that there is something which is obliterating the entire LV cavity.
Yes,
This black area, this is something, which is obliterating the entire LV.
yes.
And probably this is giving the boot kyanka. Yeah.
Boot
So
shape.
this is giving the boot
the
appearance to the
shape
heart.
of the right. So we again went to redo his echo and trying the all possible all all possible windows that could get a good window, all possible measures so that we can get a good window. And finally, in the axilla, we
No, just wait. In this
yes.
slide, now you can see the calcium in the echo
Yeah.
itself.
Yeah. Here is the calcification again over here. You can appreciate. Now we got a good window in his moving the probe to the axilla. We got a good window, and here we can see we got to see a huge aneurysm of the apex of the LV with laminar apical thrombus, which was seen in the initially, which was obliterating the window. Here again, we can appreciate this laminar apical thrombus, aneurysm within laminar apical thrombus, and the calcification. This is a short axis view of the aneurysm, which is showing clearly laminar thrombus with a calcified rim. So the take-home message is poor acoustic windows are common. We should find out a reason for a poor window. And if you can retry to find a better window, and many a times it is possible to do a meaningful echo in such cases. If we don't, someone else might. Thank you.
Yeah, thank you, Dr. Soni. Dr. Vivek, you would like to sum up this case?
Well, ma'am, actually, whatever is there is in the views only. And to be true about it, this case was done by me, and I was unable to get a proper view.
Correct.
And finding no reason why I can't have a good view. Initially, I asked for an X-ray. X-ray showed that that the apex is somewhere into the severe left. Again, we tried, we couldn't get a good window. Then we asked for a CT, and in the CT, we found that there is a calcification of the LV wall, myocardium. And because it was so much calcified, we understood, okay, this is why we are not getting a good window. And so then we tried to, try just hovering around all over the chest and actually up to the back. And then somewhere in the axilla, superior, posterior part of the axilla, we found this view. And truly speaking, the only highlight is that, yes, you do get views if you try to search for them.
Very true. Very true. So the take-home message today from this case is that, just don't shun away. Like, if the window is not proper, I know that, we all are busy in the labs, next patient is waiting for us. But, in such cases, see, such an important information was hiding, just because we were not able to make a view. And of course, whatever doctor has happened with Dr. Vivek, so does happen with all of us. So the take home message today is that keep trying, the chest gives some window somewhere. I remember that in the eco lab, whenever the seniors were around, we could never see anything, right? But when the seniors were not there, we became the seniors. Everything started,
True.
appearing before us, because we didn't have any choice. No option was there, right? So now
So
in
true.
your case also, when you retrospectively went again, after the CT, you were knowing that there is an apical aneurysm with laminated thrombus. So you tried going, here and there. So for all the beginners and freshers, the message from this case is that do not give up, just keep struggling, keep finding, and you will be able to get some image which will clinch the diagnosis. Right, Dr. Vivek?
Very true, ma'am.
Yeah.
Absolutely.
So like, we say, Dr. Manish was also saying, so I think each of the disease, suprasternal view, subcostal view, abdominal view, there are a lot of views wherein the heart, if the heart is enlarged, of course, it is going to protrude somewhere here and there. So in the chest, keep changing your views, keep sliding your probe so as to, make things more visible.
Actually, one thing which always and it many times happens when you're doing echo and you're not finding anything, patients, they test us.
Mm-hmm.
So they will never tell you that I am having dextrocardia.
Oh, yeah.
When you
Right.
are searching, and then you are going to the right side, हाँ डॉक्टर साहब मेरा heart इधर ही है. Then they will tell you. So this is very common thing. They will
Correct.
never tell you. Yes.
Correct. Yeah. So taking out the history, asking them to give their X-rays or ECGs becomes all the more very important. The moment you are unable to get a appropriate window, start asking them for more information, their prescriptions, papers, and whenever somebody is like, electively coming for the echo, ask them to bring all their records. That becomes easier. Things become easier this way. But the idea today is that keep searching and you will find it, right? So any questions? I don't think there are any questions. This was quite evident. The emphasis was, looking for windows, right? So thank you once again. And the year is ending with all these sessions. Thanking again all the people who are involved behind and in front of the screen. I would just like to thank everyone, and I wish you all a very happy New Year's Eve. And then the new year, we will join again in the new year. But I will request all of you to come forward with your cases. All of you are coming up with the cases, right? So so any strange case you would like that should be shared with other people, you should come back. You keep do a direct message to me, and we'll try to share. It is learning after all. We all are learning. The learning curve should never become flat. All right, so this is the message, everyone. And all of you enjoy this winters. Take care of yourself. Be careful and enjoy. Thank you, everyone, once again. Dr. Rakesh, are you there? Please, last message from you. Dr. Rakesh Gupta, I think he must be still busy in his OPD. So thank you, audience. And do come back. And I think everyone is aware of Eco Asia 2026. Again, inviting all of you, please register and avail the early bird registration. It will be helpful. You keep getting the information on the WhatsApp. So keep availing that. Register yourself. You're going to find it a fantastic experience, right? Dr. Tandon, is your flight likely to take, or you are going to go back home? He's
Looks
still
like he
there.
took off.
No, he's still
Okay.
logged in. He's still logged in. Chalo, anyway, it was wonderful, everyone. Reena, thank you so much once again. You are like a rock behind.
Thank you, ma'am. Thank you.
Yeah. Thank you, everyone. Good night. Enjoy.
Good night. Good night, ma'am.
Yeah.
Good night, everybody.
Thank you, Dr. Vivek. Thank you.
Good night.
Thank you.
Good night. Thank you, Ranjan. Thank you, Soni.